in the presentation. Not at all. No, not at all. You're holding. So the prone test I want to show you is Yeoman's. And this is going to hyperextend the hip. We're going to stabilize the SI joint. So you have to know your anatomy. You got to know where the PSIS is and where the PIIS is. And you have to put your hand over there. So it's going to be lateral to midline, or close to me, like that. Not midline. It's going to be right over the right bony landmarks in the pelvis. And I'm going to stabilize that. And that will allow me to hyperextend the hip. If I don't stabilize the SI joint, I'm hyperextending the hip and the SI joint. I still don't know what's going on. If I stabilize the SI joint properly, and I hyperextend the hip, and they have hip pain, what are we thinking? Problem with the hip, not the SI joint. So, because we're stabilizing. And in addition, and this is in the notes, or in the handout too, we're also stretching the femoral nerve. So what stretch test do we have for the sciatic nerve? Any of the straight leg raises. Active, passive. And that's L4 through S3. L2, 3, 4 is femoral nerve and obturator nerve, but femoral nerve is much easier to stretch. So Yeoman's is both a hip test and a femoral nerve stretch test. If they had a problem with the L2, 3, or 4 nerve roots, or a herniated disc at L1, 2, or 3, that's what an L1 herniated disc would affect L2. L2 herniated disc, L3, and L3, L4. Does that make sense? So, what symptoms would you suspect when we did Yeoman's? If they had a herniated disc, a high herniated disc in the lumbar spine? Pain where?
Down the leg.
Which part of the leg?
Front.
The front. Yes. So, when we're answering questions like that, I want you to try to be more specific. So pain, down the leg, the anterior part of the leg. And we have to do that because if you don't think that way, you're not going to record it that way. If you're not recording it that way, you're not doing your job. You could get in trouble, and at the very least, the patient could not get the treatment that they need. So, pain or any kind of symptom down in a dermatomal distribution down the front of their leg. That's what we're thinking. Just like with the straight leg raise, we're looking for pain in a dermatomal distribution for S1 and S2, which are the dermatomes in the back of the leg, posterior part of the leg. Those would just be down the back of the leg. In the front, you might notice it in more of a dermatomal distribution when you did Yeoman's. So Yeoman's, it says flex the knee 90 degrees. Michelle's knee is flexible, so I flex it more. It doesn't matter. 90 degrees is not important. What is important is my ability to grab the knee like this. I'm reaching around on the inside of the knee like this, and I'm cupping the knee. If her leg isn't that flexible, then my forearm and or my shoulder keeps the knee flexed. This hand in between the PIIS and the PSIS and pushing down to stabilize the SI joint. Then I use my legs to lift the hip, and I'm watching the low back and feeling the SI joint, making sure those aren't moving. Once I get the hip as extended as it can, I oscillate. Any pain? All right. Of course, you do this bilaterally.